Hello, my name is Dr. Lisa Ferdinand, and I am the Assistant Director for Clinical Services at the University of South Florida's Counseling Center. I'm delighted to join you and your facilitator today to talk about recognizing and responding to relationship strains and ruptures in therapeutic and supervisory relationships. Today, we are going to begin by briefly reviewing a case example that we will come back to throughout the presentation to illustrate some of the concepts I will present. Because we will continue to come back to the case, I would like to invite you to take some notes as I review it with you so that you remember the important details during the rest of the presentation. Next, we will discuss some important definitions. We will then move on to reviewing the causes of ruptures, why it is important to recognize them, and the main types. Finally, we will discuss steps to repair ruptures in therapeutic and supervisory relationships and apply these steps to the case examples. Are you ready? Let's start by reading through the case example together. The supervisee is a 28-year-old Latina, cisgender, heterosexual female. She meets with her supervisor, who is a 30-year-old white, cisgender, heterosexual female, for weekly supervision as she accrues hours for licensure as a mental health clinician. The supervisor has just met California requirements to become a supervisor and is new to the clinic. During their second supervision session, the supervisee begins sharing an experience with a new client. The 18-year-old client was reportedly adopted from China as an infant by white American parents and currently identifies as a white American. The client is depressed with some suicidal ideation. She also reports anxiety in social situations and difficulty maintaining friendships. The supervisee expresses some confusion and frustration that the client identifies as white and denies her racial identity. The supervisee additionally states, "It's obvious that many of the client's concerns are related to the difference between how she sees herself and how she is seen by others." The supervisee shares that she tried to begin sharing her conceptualization with the client towards the end of the intake, but the client seemed uninterested. The client also seemed hesitant about scheduling a follow-up session, but eventually agreed to do so. The supervisor briefly validates the supervisee's frustration. She then reminds her that race may not be a salient identity to all clients. She adds that they are a very busy clinic and, due to their high volume, they need to focus on meeting their clients' needs as quickly as possible. She redirects the focus of supervision to exploring the client's stated presenting concerns if she decides to come to the next session. The supervisee looks confused and sad. She quietly agrees with the supervisor, and the conversation shifts to managing the client's symptoms of risk, depression, and anxiety. If this supervisor had come to you for a consultation about this, what are some of the issues that you would want to help him or her unpack? So how do we define ruptures in therapeutic and supervisory relationships? A rupture can be thought of as a deterioration in the therapeutic or supervisory alliance that is usually manifested by a disagreement between the client or supervisee and therapist or supervisor on goals, a lack of collaboration on therapeutic or supervisory tasks, or a strain in the emotional bond in the therapeutic or supervisory dyad. A repair refers to efforts that we make as clients or supervisors to repair these ruptures. It's important to note that ruptures can sometimes refer to dramatic breakdowns in the relationship, such as when a client might become very angry in session and terminate. However, ruptures in both therapeutic and supervisory relationships can also be more subtle. These more subtle tensions can be thought of as strains, and importantly, they are often much harder to detect. Now that we've discussed the definitions of ruptures and repairs, let's move on to discussing the main causes of ruptures. Why don't you begin by briefly discussing among yourselves what you see as the main causes of ruptures in therapeutic and supervisory relationships? Take about 5 minutes. So there are many reasons that ruptures and strains can occur, but most of them can be grouped into 4 main categories. We will go through these one at a time. The first category refers to ruptures caused by miscommunication and mismatched expectations. These include ruptures that occur because the client and therapist disagree about the goals, expectations, or procedures used in treatment. If we think back on our case example, the client may not have expected her identity to be challenged by the therapist, potentially leading to some confusion about therapy and a subsequent rupture. In the supervisory relationship, there may be disagreement about treatment planning, roles, or evaluation expectations. For example, the supervisee may have had past supervisory experiences during which there was a significant focus on the reaction she was having to her clients, leading her to feel dismissed in the current supervisory relationship, possibly causing a rupture. The second category we will discuss refers to normative conflicts that occur in therapeutic and supervisory relationships. Given the nature of therapeutic relationships, we can expect that there will be periodic miscommunications and misunderstandings as the therapist and client work together and develop a mutual understanding of each other and their work in therapy. Indeed, alliance strains are a natural part of treatment and provide opportunities for change. These ups and downs may feel more overwhelming to newer clinicians who may be less confident, more sensitive to being evaluated, and more anxious about therapy generally. Part of our role as supervisors is to normalize these conflicts while also highlighting the importance of recognizing and addressing them. In supervision, normative conflicts may arise as a result of supervisor or supervisee inexperience, the supervisee's desire for more autonomy, sometimes without the requisite skills, as well as agency demands that may impact the clinical treatment model and the time that can be devoted to supervision. For example, in the case example, the supervisor may be balancing a desire to help the supervisee work through her reactions to the client, while also ensuring that a thorough risk assessment was conducted, given the number of clients that they may need to review during the time allotted for supervision. Given that she's new to the clinic, the supervisor may also be more aware of her own evaluation as a new clinician and supervisor at the clinic. The third category of rupture causes involves interpersonal dynamics. In therapeutic relationships, research suggests that ruptures may be more common with clients with certain interpersonal characteristics, including specific attachment styles, personality characteristics, and negative views of themselves and others. It is often also harder to repair ruptures with these clients. It's important to note that although negative reactions to these clients may be understandable, failure to adequately contain them and respond appropriately may lead to ruptures and precipitate termination. As such, in supervision, we can help our supervisees to be more attuned to these potential dynamics as they conceptualize and treat their clients. We can certainly hope that the frequency with which attachment and personality variables negatively impact the supervisory relationship is lower than in therapeutic relationships, although this is not always the case. The shame resulting from intrapersonal and interpersonal dynamics is common among newer clinicians due to the range of novel tasks that they are attempting to master, and it is important that supervisors refrain from providing feedback in a shame-inducing manner that may lead to ruptures. Supervisors must also strive to be aware of the impact of parallel process and boundary violations on creating potential ruptures in the supervisory relationships. These will both be discussed at length in subsequent lectures, so we will not focus on them more today. The final category of rupture causes refers to cultural conflicts. These occur when clients or supervisees perceive that an aspect of cultural identity was targeted or implicated in the rupture. For example, in the case example, if the supervisory rupture is not addressed, the supervisee may conclude that the supervisor redirected the focus of supervision because she is multiculturally incompetent. As the importance of providing multiculturally competent supervision has already been covered in a recent lecture, we will not discuss it further here, but it is important to note as supervisors that discrimination based on cultural characteristics is a common theme in harmful supervision narratives by supervisees and is therefore likely a key cause of ruptures in the supervisory relationship. So far, we have defined ruptures and repairs and considered 4 categories of causes of ruptures. Now we will move on to discussing how to recognize ruptures in therapeutic and supervisory relationships. Let's begin by asking you to discuss why it is important to recognize ruptures in these relationships as quickly as possible. Can you identify which of the 7 counties regional partnership core competencies are relevant to addressing ruptures? Take about 5 minutes. Okay. So in thinking about why it's important to address ruptures in the therapeutic relationship, and to do this early, it's important to note that research suggests that the quality of the therapeutic alliance is a robust predictive treatment outcome. And this has been found to be true across a range of treatment modalities, including the short-term and brief treatments that are often relied on in busy clinics. Moreover, the failure to address ruptures has been associated with client dropout. While it would be ideal if clients would always let us know when there is a strain or rupture in the therapeutic relationship, due to the power difference in the relationship, this is unlikely. As such, training our supervisees to recognize ruptures is an important part of supervision, and such training has been associated with positive treatment outcomes. We can also train our supervisees to discuss how strains and ruptures could be managed at the onset of therapy. For example, this could occur during the intake session, as a part of informed consent, or at another point in the intake session. This may allow clients to more easily bring up ruptures when they occur if supervisees miss them. As we consider this issue in supervision, it is vital that we continue to remember that strains and ruptures are common and expected. As such, the presence of ruptures is less of a concern than if and how these ruptures are addressed by our supervisees and if and how they implement recommended suggestions. I've listed the SCRP competencies that are relevant to teaching our supervisees to recognize and address ruptures. As you can see, most of the competencies are relevant, and as we will discuss in the section on repairing ruptures, helping our supervisees to be reflective about themselves and their experience in therapy is particularly important in recognizing and repairing ruptures. It is also important to quickly detect and address ruptures in the supervisory relationship, as, if unrecognized, these have the potential to derail or destroy the supervisory relationship. As with the therapeutic relationship, due to the power difference, the primary responsibility for addressing ruptures lies with the supervisor. Moreover, because ruptures may reduce the willingness and ability of supervisees to share what is occurring in supervision, ruptures in the supervisory relationship significantly reduce the ability of supervisors to monitor treatment and protect the client, a primary supervisory responsibility and ethical imperative. Addressing ruptures in the supervisory relationship also models for supervisees how to do this well in the therapeutic relationships, and is unlikely to reinforce avoidance as an appropriate strategy when ruptures occur. As with the therapeutic relationship, discussing how ruptures and strains will be managed at the onset of supervision, perhaps as a part of the supervision contract, may increase the likelihood that supervisees will take the courageous step of bringing them to the fore if the supervisor does not notice or address them. Now we've discussed the four main causes of ruptures and established that recognizing ruptures is an important therapeutic and supervisory competency. But what do ruptures look like? As you think back on your own therapeutic or supervisory relationships, what are signs that a rupture has occurred? What about strains? Take about 5 minutes to discuss. Ruptures can be divided into two main types: withdrawal ruptures and confrontation ruptures. In withdrawal ruptures, the client or supervisee move away from the therapist or the work of therapy, or the supervisor or the work of supervision. For example, we're all familiar with clients who continue to schedule sessions, but who cancel them or arrive late for them despite their continued assertions that they want to continue counseling. In its most significant form, clients may withdraw completely from the therapist and therapy by prematurely terminating. In the case example, there's some evidence that the client may be withdrawing, given her hesitancy to reschedule a follow-up session. In supervision, we may notice that a supervisee who used to ask questions about interventions or share openly about their experience in sessions may become more reserved or compliant. Supervisees may also become more hesitant about openly discussing their clinical challenges and may be reluctant to show session recordings. It's important to remember that although our supervisees may want to terminate supervision, they're usually unable to do this without significant consequences. As such, it's important for us to be attuned to and address withdrawal ruptures. Can you recall any signs of a withdrawal rupture in the supervisee in the case example? Because withdrawal ruptures and strains can be more subtle, using ongoing outcome measures that capture changes in the bond score can be very beneficial. In addition, therapists and supervisors may become most aware of withdrawal ruptures and strains by noticing and exploring changes in their own reactions to clients and supervisees or their experience of therapy and supervision. This is an important skill that we can teach our supervisees to monitor. As you might expect, the nature of confrontation ruptures makes them easier to detect. In these ruptures, the client or supervisee is moving against the therapist or supervisor and/or the work of therapy or supervision. For example, a client may share her anger or frustration at not feeling listened to by her therapist, or a supervisee might challenge the supervisor's treatment plan. In the case example, if the supervisee had openly shared her concern that the supervisor was redirecting supervision because she was culturally incompetent, this would have been an example of a confrontation rupture. Now that we have identified ruptures, identified their four main causes, reflected on why it's important to identify them quickly, and discussed what they might look like, it's time to turn our attention to how we can repair them. Please take just a few minutes to brainstorm the main steps you usually use to repair ruptures in therapeutic and supervisory relationships, and then we will get started. The first step in repairing ruptures is, unsurprisingly, identifying that one has occurred. We do this by attempting to identify when exactly the rupture occurred, in part by looking for signs of strains, withdrawal ruptures, confrontation ruptures, or a combination of all of these signs. As noted earlier, if addressing ruptures is discussed explicitly as a part of informed consent with clients and supervisees alike, it may increase the likelihood that they will bring these up if they go unnoticed or unaddressed by therapists or supervisors. In addition, being aware of changes in your reactions to supervisees and supervision and teaching supervisees how to be aware of their reactions may enhance the ability to notice less obvious strains and ruptures. Finally, using an outcome measure that identifies when the bond score has been disrupted and recording both client and supervisory and therapeutic sessions both increase the likelihood of quickly identifying that a rupture has occurred. As we think about the case example, when did the rupture occur in the therapeutic relationship? What about the supervisory relationship? Okay, so the second step in repairing ruptures involves identifying contributing factors to the rupture. A significant part of this process involves stepping out of the relational dyad and teaching supervisees to do the same so that you can assess what has happened and avoid unintentionally reinforcing negative patterns of interaction. In considering the causes of a rupture, it is helpful to consider the 4 categories of causes already reviewed, as well as how client variables, supervisor variables, supervisee variables, and contextuant variables may all be contributing to the rupture or strain. It is important to note that the supervisory process is not intended to determine the nature of the rupture in isolation of the client. Rather, supervision can provide a means for collaborating with the supervisee to identify the initial sources and natures of the rupture through consideration of possible causes, including consideration of the therapist's cognitions, attributions, affects, and behaviors that may have impacted the relational dyad. Supervision can also help the supervisee to consider the interactions from the perspective of the client, which may allow empathic understanding of the client's withdrawal or confrontational behaviors. This may be accomplished through a variety of techniques such as role-playing, empty chair, or other interventions that facilitate self-reflection and reflection on the client's experience. Finally, supervision can provide support and clinical direction to initiate resolution of the rupture. What were the possible causes of the ruptures in the case example? So the third and perhaps most challenging step in repairing ruptures is engaging in the process of rupture repair. This step begins with therapeutic metacommunication, which consists of an attempt to step outside of the relational cycle that is currently being enacted by treating it as a focus of collaborative exploration. During this process, the supervisor or therapist collaborates with the supervisee or client in being curious about what is happening between them and encourages the client to share their experiences of the interaction. It is important that during this process, the supervisor and therapist focus on normalizing and validating the experience that is shared, and therefore managing any reactions they may be having to the content of what is shared. Learning to tolerate, validate, and empathically explore your own reactions and teaching your supervisees to do the same are important skills in repairing ruptures. It is equally important during the rupture repair process that the therapist or supervisor accept responsibility for their participation in the rupture. This can be done by drawing from the literature on humility, which suggests that demonstrating openness to shared perspectives, willingness to acknowledge mistakes and limitations, and the ability to focus on the experience of others may all be beneficial when repairing ruptures. Once you have engaged in collaboratively exploring the experience of the rupture, it may be helpful to discuss the impact on the therapeutic or supervisory relationship and what steps could be helpful in realigning goals and strengthening the bond. These may include reviewing the rationale for therapeutic or supervisory goals and process, changing the goals or tasks, clarifying any misunderstandings, or exploring relevant relational themes that have emerged. Please take a few minutes to discuss how these steps could be applied to the therapeutic rupture in the case example. What about for the supervisory rupture? The final step in repairing ruptures involves assessing whether or not the rupture seems to be resolved. This can be done by assessing if there seems to be a shared understanding of the goals and tasks of therapy or supervision. Does the supervisor or client seem to buy in to these goals and tasks in a way that they may not have before engagement in the rupture resolution process? We can also assess for reductions in confrontation and withdrawal behaviors that signify the rupture. For example, has the supervisee begun to more openly discuss clinical mistakes? And has a client stopped missing sessions? Finally, as highlighted throughout this presentation, using ongoing bond measures can be very helpful in this task As one would expect, the therapeutic and supervisory bond scores to improve on such measures if the repair was successful. It is important to note that because the clinical task of repairing ruptures is essential to the efficacy of treatment, the supervisor's contribution to the rupture repair process and to ensuring that ruptures are resolved is a demonstration of the supervisor's commitment to provide the highest quality of care to the client. In some instances where the alliance rupture cannot be resolved, the supervisor may have to intervene directly with the client to safeguard the client's welfare and treatment, and to reestablish an alliance between the client and the mental health clinic to determine a collaborative treatment option that re-engages the client. Based on your knowledge of the case, briefly discuss how you think the supervisor and supervisee in the case example could assess for rupture resolution. In summary, in this lecture, we have defined ruptures and repaired, explored 4 categories of causes of ruptures, examined why we should and how to recognize ruptures, and finally reviewed steps that could be used in repairing ruptures. I hope you've enjoyed this lecture and will be able to successfully implement the strategies suggested in your supervisory relationships.